Hi, my name is Dr. Jones, and I'm going to talk today about abdominal aortic aneurysm. I'm a preventive medicine resident at Tulane University right now in the complementary pathway. So during this presentation, we're going to discuss epidemiology, including risk factors, statistics, and prevention. Next, we're going to discuss normal anatomy versus pathology with some pictures. Thereafter, we're going to discuss pathogenesis, followed by the United States Preventive Services Task Force recommendations. We're going to talk shortly on AAA screening and jump into subjective complaints and objective findings for patients with AAA, followed by various imaging modalities, followed by medical and surgical treatments. And lastly, we're going to discuss some complications that can occur from these. Next, I want to discuss the epidemiology of abdominal aortic aneurysm development. But first, we need to understand what is the abdominal aortic aneurysm. And it is an enlarged area of the aorta that is greater to or equal than 3 centimeters, usually is measured by ultrasound. Next, I want to talk about the prevalence, which today is approximately 0.5 to 3.2%, depending on which study you read. The mortality is quite high. And ruptured AAA is the 13th leading cause of death, with approximately 15,000 deaths yearly and a frequency of approximately 4.4 per 100,000 persons. Most of these AAA-related deaths occur in women 80 years or older. Smaller AAAs are more likely to rupture in women and rupture at an older age than in men. The operative AAA mortality is also higher in women than in men, particularly after endovascular and open repair. Women also experience higher rates of other harms, such as major surgical complications. And aortic aneurysms caused approximately 9,928 deaths in calendar year 2017. So to summarize again, regarding women, they have a higher risk of rupture. They rupture at smaller diameters than men. They have a higher intraoperative mortality and a higher postoperative mortality. These are things that are often not discussed, as they generally talk about smoking males, mainly when discussing AAAs. Causes and risk factors will be discussed in the upcoming slides. Some of the causes of abdominal aortic aneurysm include atherosclerosis, hypertension, various blood vessel diseases, rare bacterial or fungal infections of the aorta, and of course trauma. When discussing risk factors associated with abdominal aortic aneurysm, we need to really focus on 3 different areas. In regards to the development of a AAA, advanced age, male sex, Caucasian race, strong family history of AAA, smoking, history of large vessel aneurysms in that same patient, atherosclerotic risk factors, hypertension, and obesity. Again, all these are for the development of a AAA. Risk factors associated with expansion of a AAA, including smoking, an increased diameter already, or a cardiac transplantation. Risk factors associated with actual rupture of a AAA include smoking, female sex, an increased diameter, hypertension, a family history, and COPD. And the one thing that I want to point out is that for development of a AAA, male sex is associated with that risk factor, but with rupture, it's female sex. And the other thing I wanted to point it out, with the development, expansion, and rupture of AAA, all 3 are strongly associated with smoking. Being in a preventive medicine residency, of course, I had to add the prevention of AAA into my slides. And this is from the Mayo Clinic. And the first and most important one is don't use tobacco products in the first place. And if you do, quit smoking or using tobacco as soon as possible. Number 2, eat a healthy diet. Keep your blood pressure and cholesterol under control, and get regular aerobic exercise of approximately 150 minutes weekly. In this slide, I wanted to give a simple illustration as to normal and abnormal anatomy, something that could easily be seen. And in looking at these two aortas, you can obviously see the one with the large abdominal aneurysm there. And the initial vessels, you can see there are the inferior phrenic. You can see the celiac artery, the superior mesenteric artery, and then going down further, you can see the bilateral renal arteries, the gonadal arteries, inferior mesenteric artery, and down to the common iliac arteries. This slide shows the normal anatomy and blood vessels on the left. On the upper right, you can see the true kinds of aneurysms that include the saccular and fusiform and the false aneurysm, kind of comparing the three. In addition, you can see the aortic wall that contains concentric layers of smooth muscle, elastin, and collagen, with elastin as the principal load-bearing element that usually resists aneurysm formation. This is a fantastic intraoperative picture. You can see that this aorta is enlarged. It's also quite tortuous. So it's most likely an elderly person. You can see the omentum clearly, and so as soon as they open the abdomen, you can see this very large aorta staring at you. This image is from the pathologic specimen from a ruptured abdominal aortic aneurysm. And you can see the common iliacs on the far left-hand side there and see where the aneurysm is clearly dilated in the middle of the picture. I'm not a pathologist, but I thought we should include a couple slides in here. And this one you can see the fibrosis, most superior part, as well as extensive layer of inflammation, and in the area of the adventitia. This slide zooms in a little bit more into the adventitia, showing the massive amount of inflammatory cells that are mainly composed of lymphocytes, plasma cells, and eosinophils. Regarding the pathogenesis of abdominal aortic aneurysm, you can really get lost in the weeds here with all the research that's been done. It was originally considered just to be from atherosclerotic disease. However, we've also found that through embryology and histology of the inferior renal aorta that there is an absence of the vasa vasorum. And the inflammation in the Th2 response has been blamed for some of the pathogenesis, as well as smooth muscle cell apoptosis. In addition, extracellular matrix degradation, particularly in the form of the matrix metalloproteinases, have been blamed, and this area has been probably researched more than some of the others, as well as defective fibrillin and poor microfibrillar integrity, as with Marfan's syndrome. In regards to AAA screening, the U.S. Preventive Services Task Force has made some recommendations, as I have listed in the table here. Men aged 65 to 75 who have ever smoked, it's a grade B recommendation. And I want to point out that this is for a one-time evaluation. So it's important that you find out if the patient has ever had one before you go ordering one. Next is men age 65 to 75 who have never smoked. That's a grade C recommendation. In regards to women who have never smoked, it's a grade D recommendation. Conversely, women aged 65 to 75 who have ever smoked, it's a grade I recommendation. So when a patient has a AAA, what are they going to complain of? Well, most of the time they're completely asymptomatic, which is approximately 65 to 75% of the time. These are the patients we want to do the preventive screening on. Now, if they're complaining of other things, that would be a diagnostic evaluation rather than a preventative screening. And some of these include severe persistent pain, which is many times in the abdomen, back, flank, hip, and groin. It's rapid onset, and many times these patients describe a pain described as ripping or tearing. Some patients with inflammatory kinds of aneurysm may have weight loss, nausea, and vomiting. Those are pretty vague symptoms. Other very important things to look for include lower extremity ischemia, in which an embolization of a thrombus or plaque, ruptured and traveled distally. Leg edema, this could be from IVC compression or even heart failure from an aortocaval fistula. Some patients may get tenesmus, kind of like when you're having a baby and you feel the urge to push. They may have a feeling to have a bowel movement. This is pretty rare, but it can happen. Other symptoms, especially if it's ruptured, are going to be fainting, syncope, weakness, dizziness, and unfortunately, there's sudden death at approximately 4 to 5% of these patients when it is ruptured. We've discussed subjective complaints. Now let's discuss objective findings. The classic triad is abdominal or back pain with a pulsatile abdominal mass and hypotension. This occurs, unfortunately, only in about a third of patients with a ruptured AAA. They can also have abdominal tenderness, CVA tenderness, and abdominal brewery or machinery kind of murmur, especially with the aortocaval fistulas. If they're ruptured, they're going to have hypotension and shock. You may have those decreased femoral pulses from the distal emboli or atherosclerotic plaques. You may see periumbilical ecchymosis, known as Collins sign, or flank ecchymosis, known as Gray-Turner sign, both occurring from a hemoperitoneum. In addition, you can have obvious severe anemia, DIC, those things on lab findings. Physical exam overall is not great at picking these up. It has a sensitivity of only about 39 to 68% and a specificity of approximately 75%. So we mentioned that physical exam is not great for picking these up. What can be? X-rays sometimes can pick these up before they're ruptured. Ultrasound is probably the most common way we evaluate both preventative and diagnostic. Sometimes computerized tomography or CT is performed. And in rare circumstances, MRI may be used, and we'll go into details on why that may be. So when you find a AAA on a plain X-ray, it's usually accidental or an incidental finding, but these can be seen in approximately 60 to 75% of cases. And many times it's pretty easy to see with the calcifications evident in the aortic wall. Sometimes this can be seen as a paravertebral mass. The most beneficial view is the cross-table lateral. And when you have a negative study, it's not really helpful because you can't always see these unless you have the calcifications in the aortic wall, as I mentioned. So here are some X-rays showing an abdominal aortic aneurysm, and with the help of the arrows, you can kind of delineate the aneurysm on the left. And on the right, you can see the calcified abdominal aortic aneurysm outlined a little better than the one on the left. So this slide is a side-by-side comparison of pros and cons for ultrasound for abdominal aortic aneurysm. You can see right away that there's a very high sensitivity and specificity with this procedure. It's non-invasive, it's cheap, it avoids radiation exposure, it's very reproducible. It can be done in the office, ER, or radiology, and we'll talk more about that in a minute. The measurements of the abnormalities in the aorta can be demonstrated to within approximately 3 millimeters as compared with surgical specimens. Some of the cons are that the imaging of the upper part of the aorta is sometimes obscured by bowel gas, and pressure has to be placed to displace the bowel, which is uncomfortable to patients. They may not be able to tolerate it, especially above the renal arteries. And many times it's harder to delineate the extent of the involvement of the smaller arteries, as I mentioned before, like the mesenteric and iliac vessels, for example. Hocus pocus. I can't say pocus without saying hocus, but This is the screening of the abdominal aortic aneurysm. It stands for point of care ultrasound screening, and it is the ideal way to diagnose AAA. It can be done in the office. It is the best way to diagnose these things early when they're asymptomatic. And it allows you to decide what to do with patients based on those findings. It may be that you have to refer them on, it may be that you just continue to follow them, but it allows those early decisions which can help, like control of blood pressure, cholesterol, etc. It improves clinical care. It allows for non-emergent disposition, so you don't have to wait for it to rupture to know the patient's got a AAA. And overall, it can save lives. As I did my research for this presentation, I come across a very important bill called the SAVE Act. And this allows for, and that stands, by the way, for screening abdominal aortic aneurysms efficiently. But this allows for insurance companies to cover a one-time screening, particularly for men 65 and older who have smoked, and smoke is defined as 100 cigarettes in their lifetime, or for women who have had a family history of AAA disease. This was originally passed in December 2005 and was further expanded in 2009. It's important because it authorizes HHS, Health and Human Services, to modify coverage of preventative services consistent with the United States Preventive Services Task Force. And as you know, CMS and other insurance companies focus on this heavily. And so when this was passed, this allowed for us to get ultrasounds paid for our patients. So we've already discussed POCUS, or point of care ultrasound. This is a little different. This is called FAST ultrasound, FAST standing for Focused Assessment with Sonography for Trauma. And this particular study that I'm referencing here showed how this can save lives because of the speed in which the evaluation can be performed. So the average time to diagnosis by the bedside ultrasound was only 5.4 minutes. If you had to send them by CT, that's at least 83 minutes, they found. The average time to the OR for diagnosis by ultrasound was 12 minutes. If you used CT and then sent them to the OR, it was about a 90-minute turnaround time, which may be too late for a lot of patients. The ultrasound images here on the left are in a coronal or longitudinal view with a vena cava on top, and you can see the aorta underneath. And this is very high, as you can still see the liver and the sinusoids. And on the right, you can see another image of the same. These ultrasound images are transverse through the normal aorta. You can see the normal aorta on the left. And if you follow that down far enough, you'll see it bifurcate into the common iliac, which is visible on the right. So here's a nice ultrasound of an abdominal aortic aneurysm with a very large thrombus. And on the left, you don't see any arrows, so you have to figure out things on your own. But if you look over on the right, it kind of shows everything for you. So you can see that lumen is very irregular. Probably there's been plaques that have broke up already. If not, the patient is extremely prone to this. You can see one kind of flipped up at the 6 o'clock position. You can also see the very large irregular thrombus. That whole thing can break off and go distally as well and cause a decrease in the pulses and ischemia of the distal legs. So I'm not a radiologist or a vascular surgeon, but my interpretation of these ultrasounds on the left shows a very narrow lumen in the bottom right-hand corner with a very, very large thrombus throughout the majority of a quite distended or dilated aorta. And on the right is a color flow Doppler showing the same. And, I don't think it's the same person. It could be, I suppose, but I do see a thrombus formation at approximately the 6 o'clock position that is concerning. This may be a different patient, though. After all the imaging I've shown, you can kind of see in this picture a dilated abdominal aorta as well. You can see the very large thrombus throughout the majority of it, and it looks like the only lumen available is approximately at the 3 o'clock position. You see that gray, the darker gray, and it's somewhat irregular as well. This ultrasound picture is a little blurred, but you can clearly see from the black how the aorta increases in the diameter from the left side as it goes toward the right side. And the largest dilation here is 6 centimeters, as you have listed there in the bottom left of that picture. And this is a longitudinal, so your ultrasound probe would be in a superior-inferior position in the midline. So this slide shows a side-by-side pros and cons comparison of CTs for diagnoses of abdominal aortic aneurysm. Some of the pros include the fact that it's 100% accurate. It's very sensitive and specific in detecting these. It has a better demonstration of the extent of the aneurysm, particularly the upper part of the abdomen, where it's sometimes difficult to visualize. In addition, some of the peripheral vessels, like the mesenteric and iliac vessels, you could obtain a better imaging of those areas. And then, of course, afterwards, if you have a complication after a surgery, many times CT is a better way to evaluate that. Some of the cons is that it allows the patient to be exposed to radiation, which is pretty high dose. Requires use of contrast, which can harm the kidneys and cause allergic reactions, as well as increase the costs of the procedure, and it takes longer to complete as compared to ultrasound. The picture on this slide is a CT without IV contrast of a ruptured abdominal aortic aneurysm, and you can see the A is the center of the aorta. You can see the clear calcifications around this dilated aorta, and you can see extravasation of the contrast in the blood, as evidenced by the arrow. This is another CT scan of the abdomen showing an obvious abdominal aortic aneurysm. The white you could see is the contrast in the lumen, and you can see it's not very circular. It's kind of oblong, and around the periphery you can see that gray line, which is a thrombus that's forming. This CT of the abdomen is a little easier to see and kind of looks like an egg to me, but you can see the central portion of the aorta where blood is flowing. That looks very white, and you can see the peripheral clot around the periphery, and you can see that the overall diameter of that aorta is quite dilated. So why would we ever do an MRI on an abdominal aortic aneurysm? Well, if you're really trying to delineate all the abnormalities, it's more accurate than a CT scan. It is the most expensive. It's not available for emergency departments, and many times has to be accomplished on an outpatient setting. But it is superb, particularly combined with angiography. As you can see, all the related vessels that may need to be repaired with the aneurysm. This is an MRI with angiography. And you can see on the left-hand side, the aneurysm is pretty easily demonstrated with some increase in diameter of the distal aorta going into the iliac vessels as well. And in the middle, you can see the lumen of the aneurysm with some clot formation in it. And the 4D flow is pretty cool with the colors added into the imaging there. You can clearly see the aneurysm there as well. So again, I'm not a vascular surgeon, but I made this slide as a tool to kind of detail what would happen for each of the scenarios. So obviously, if you evaluate a person and find that they're ruptured or they're dissecting, that's going to be an emergency surgery. If it's greater than 5.5 centimeters, there's usually a referral followed by an open surgery. It's generally not immediate. It's something that can be scheduled and planned. For those 3.0 to 5.4 centimeters, as a general rule, conservative management with repeated ultrasound every 3 to 12 months is appropriate, as well as medical treatment like controlling hypertension and hyperlipidemia. However, regardless of the size, if these are rapidly expanding of more than a centimeter per year, surgical referral of these smaller aneurysms would be appropriate due to their rapidly changing diameter. Guidelines from the Society for Vascular Surgery recommend repairing AAAs between 5 and 5.4 in women. Again, as I mentioned before, due to the fact that they rupture at smaller diameters as compared with men. And any patient that has a symptomatic abdominal aortic aneurysm generally is referred for surgical repair regardless of the size. You may ask, how do we arrive at the information mentioned in the previous slide on knowing when to act and when not to act? It's basically based off of several studies. And so anybody that's less than 4 centimeters diameter, the risk of rupture is low. It's quoted as 0%. If it's 4 to 4.9, studies have reported anywhere between 0.5 to 5% rupture. The United States Preventive Services Task Force quotes 1% there. Those that are 5 to 5.9, there's about a 3 to 15% of rupture, with the US PSTF quoting 3 to 11% rather, sorry. And you can see the larger it gets, the higher the risk of rupture. So 6 to 6.9, 10 to 20% of rupture, 7 to 7.9, 20 to 40%. If it's bigger than 8, 30 to 50% risk of rupture. So this is what guides when we act, and we can use these statistics to talk with patients and let them know what their risk of rupture is based on these studies. So what do we do if a patient has a small abdominal aortic aneurysm and we do medical treatment to follow them? What do we do exactly? Well, one, we try to get them to stop smoking. We give beta blockers. Sometimes we give antibiotic therapy if it's more an inflammatory type of aneurysm. We focus on risk factor reduction, particularly in regards to weight, their blood pressure, and their cholesterol. And then, of course, we do serial ultrasounds to follow these aneurysms. Again, I'm not a vascular surgeon, but what kind of perioperative management would you do if you're involved in a case like this? It'd be mostly standard things, including preoperative antibiotics, beta blockers, bowel prep. You'd need IV access and probably an art line, a Foley catheter to monitor INOs. A cardiac screening would be appropriate. A cell saver in the operating room would be important, so you wouldn't have to transfuse this patient necessarily, as well as typical things like sequential compressive devices to prevent DVT, etc. So I made this slide to show a side-by-side comparison of the endovascular repair versus the open repair. And you can see the endovascular repair is less invasive, it's less expensive, there's less morbidity to it. However, look at the next one. There's a greater risk of late mortality in aneurysm rupture as compared to the open procedure. That's the one big take-home message from the choice of surgical repair. Everything's better for endovascular with the exception of that. I mean, there's a shorter hospital stay, shorter recovery, less blood loss, faster return to baseline. But again, there's a greater risk of late mortality and aneurysm rupture with endovascular as compared to that open aortic repair. This slide is amazing to me. On the left, you can see the aneurysm, and on the right, you can actually see 3 different stents being deployed, one from superior and one through each iliac vessel to repair this aneurysm that was involving the common iliac vessels. This is a slide of another endo repair showing those endovascular stent grafts being applied. This slide shows various open aneurysm repairs in which you can tailor the repair to the affected vessels. And starting at the top, that's extent 1, middle is 2, top right is extent 3, and then 4 and 5 you can see are properly labeled on the bottom. But you can work around vessels that are uninvolved, yet include those that are involved as you get lower into the iliacs, for example. This is a nice illustration of how this occurs. So repair of abdominal aortic aneurysm is not without its complication, and the most common complication is cardiac. Usually happens within the first couple days post-op. This is less likely if you can keep the hematocrit above 28, control the pain, and prevent the patient from going into tachycardia, keep that pulse under control. The next most common thing is distal embolization, which can happen even before the procedure, but you want to check the toes and check the pulses to make sure that that's not happening. Hemorrhage is not common from the aorta. They usually would become immediately noticed, obviously, within a surgical procedure, but it's those venous bleeds that are slower that can happen. Renal failure can occur, and it's usually from an embolus. Colon ischemia is very rare, but it is very lethal, and patients that have had a previous colectomy are the ones it usually happens in. And the best thing to do there is just watch for bloody stools and consider an early sigmoidoscopy if necessary to evaluate these bloody stools. Impaired sexual function is very common post-procedure, as these autonomic nerves run along that left distal aorta and are generally severed in the process of the procedure. Graft infection is only 0.5% overall. Graft thrombosis is approximately 3% overall at 10 years. An anastomotic pseudoaneurysm can be seen, as we mentioned back with the normal and abnormal. Intima, we were talking about saccular and so forth. Those pseudoaneurysms can be seen, and usually, again, it's going to be picked up by a CT or MRI rather than an ultrasound, but sometimes it can be seen by ultrasound as well. And lastly, the aortic cable fistula we've talked about. That can lead to heart failure, machinery murmur, etc. That is a rare complication that does happen after these procedures. So during this presentation, we discussed epidemiology, including risk factors, statistics, and prevention. We discussed normal anatomy versus pathology. We discussed pathogenesis, the United States Preventive Services Task Force recommendations. We discussed AAA screening. We discussed subjective complaints that patients may have and objective findings. We discussed various imaging modalities and why some are better than others. We discussed medical and surgical treatment options. And lastly, we discussed complications. Hope you enjoyed the presentation, and I look forward to providing another lecture in the near future. Thank you.